supported by the Health and Human Services Administration, and information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. We do not have any financial disclosures at this time. So usually we like to have everyone take the time to quickly introduce themselves. So if you can, using the chat function, please list your name, role, your site, and your location. Our hub team will go ahead and introduce themselves on video so you can get to know us. My name is Nika Seville, and I'm the project manager for our Geriatric Workforce Enhancement Program at the UC Irvine Health, and we are located in Orange County, California. So we'll go ahead and have the rest of our hub team go ahead and introduce themselves. Dr. Sagal.
Hi, I'm Sonia Sagal, and I am one of the geriatricians at the UC Irvine Senior Health Center, which is affiliated with UC Irvine Health, and we're located in Orange, California. It's my pleasure to welcome you all here.
Thank you. Dr. Grivich.
Hi, I'm Tanya Grivich. I'm a clinical pharmacist. I work at UCI Senior Health Center, and I also teach at USC Pharmacy School. I teach their geriatrics curriculum. Thank you for having me.
Thank you. Camille.
Hi, everybody, and welcome. I'm Camille Fitzpatrick, and I'm a geriatric nurse practitioner over at our FQHC in Santa Ana, where we teach family medicine residents and nurse practitioner students, and we have a wonderful clinic on Wednesday mornings. So welcome. Thank you.
Thank you. Dr. Gibbs? She might be running late. And Carlos?
Hi, everyone. My name is Carlos Garcia. Oh, she's here?
Yeah, she's muted.
I'm sorry,
Dr.
Carlos. No, I was muted.
Hi, everyone. My name is Carlos Garcia. I'm the Geriatric Workforce Enhancement Program Data Analyst, and it's a pleasure to be here.
Dr. Gibbs?
Hi there, Lisa Gibbs, Division Chief of the Geriatric Medicine and Gerontology, and I met you last week, and it's great to have you back. Okay.
Thank you all. Any of our other hub members on the line? Okay. Thank you all for introducing yourselves in the chat. Looks like we have a great number of people here, so thank you all for being here today. Let's go ahead. So we'll go ahead and get started on our didactic presentation. That is going to be led by Dr. Sonia Sagal and Dr. Tatiana Grivich today.
Thank you, Nika. So this afternoon, we're going to review very briefly depression and anxiety. And I will talk a little bit about kind of the diagnostic aspects of depression and risk factors, and Dr. Grivich will talk about the pharmacologic management of these conditions. Next slide. So we have 3 objectives for today. We're going to review key features of depression and anxiety in the older adult population. Hopefully, we'll review risk factors and things that you should look for when interviewing and interacting with older adults that might clue you in on these conditions. We're going to discuss the medical workup for patients, and then we'll also discuss management strategies, both pharmacologic and non. Next slide. So what is it? What is depression? I think we all have an innate understanding of what low mood and depression is and what it feels like and what our patients might be experiencing. But when we think about the actual definition of depression, we have a few key characteristics that the DSM has put forth. And the actual, sort of book definition as per the DSM is 5 out of the following 9 criteria. So your patient or client must experience depressed mood, sleep disturbance, a lack of interest or pleasure in activities, guilt or feelings of worthlessness, a lack of energy, loss of concentration or difficulty making decisions, some change in weight or anorexia, psychomotor agitation or retardation, and suicidal ideation. And this can be remembered with the SIGI-CAPS mnemonic. Next slide. Now, a more practical approach to identifying depression in patients and clients would be to use the Patient Health Questionnaire 2, the PHQ-2 screening instrument. It is a quick tool, it is validated, it is effective, and it's wonderful to screen populations of older adults for symptoms or signs of depression. And a positive score would be indicative of the diagnosis of major depression. And what we would ask, or your staff members could ask for you, would be over the past 2 weeks, how often have you been bothered by the following? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless. And there is a scoring criteria, which I included on the slide for your reference. But if somebody does screen positive, you would then move on and you could use the PHQ-9, a little bit of a lengthier questionnaire, which could further give you information about their mental health status. And the reason why I like the PHQ-2 is because it is a great screening tool. And we know that older adults who are depressed often don't present with sort of the classic features of depression, and often our patients won't disclose that they are feeling low. And then finally, this is a quick tool that your staff, your medical assistants could also administer. Next slide. Now, let's talk a little bit about some features or symptoms of depression specifically related to our older adult patient. So these patients might complain of persistent pain that is vague, that you have evaluated using multiple modalities, and you can't really understand why the patient is having frequent complaints of pain that may not be found to have an actual pathologic reason. They might complain of fatigue, and after a significant medical workup, there really is no, you can't find an underlying cause for their fatigue. They can definitely have insomnia, and we know that older adults sleep differently than younger people, and this complaint can be exacerbated by low mood. Other complaints, other somatic complaints like headaches, unexplained GI symptoms, may also be presenting symptoms. And then of course, frequent office visits or use of medical services. So they're coming in multiple times for multiple complaints that might be vague. And despite a workup, you're not able to find an underlying cause. And then when you really try to pin them down and ask, maybe perform the PHQ-2 or 9, maybe you're finding that these visits are related to low mood. And of course, social isolation, isolating from family or friends might also be an indicator. Next slide. Now, other symptoms might be delayed recovery from medical or surgical conditions. So let's say, for example, your client or patient has had a recent knee replacement or other surgery for which they have met the time requirements for recovery. They've gone through physical therapy, they've gone through all of the appropriate medical steps, and they still are complaining of fatigue or pain or loss of function. Sometimes patients with cognitive issues related to depression might refuse treatment. This might be related to passive suicidality or just not wanting to come in, leave their home and come in and get medical treatment. And it's important to remember that depression and dementia share similar features, particularly in patients who have early dementia, and there can be a significant overlap. So sometimes a symptom might be some cognitive symptoms, such as short-term memory impairment, difficulty recalling appointments, recalling specific details that they would otherwise know to remember. Next slide. Now, depression in our older patients is more common than we think. The prevalence in primary care clinics reaches up to 10%. Nursing home residents up to 20%, and hospitalized older adults 45%. And recurrence rates, so recurrence of depression can be as high as 40%. And again, this is challenging to diagnose in our older patients. They don't often present with the classic low mood. They are often hesitant to disclose their symptoms. And medical issues that might cloud the diagnosis and lower functional expectations can obscure the extent of the disease. And so what I mean by that is if someone is homebound and functionally impaired, their life may not be restricted by low mood as much as someone who is active and engaged in the community. So it's harder to actually see and detect in someone um, who has a little bit of a lower functional status. And then, of course, depression is associated with increased use of health services, excessive disability, worse health outcomes, including mortality. So it is really important that we address low mood in our older patients. Next slide. There are risk factors that I like to keep in mind, and certainly if I see these risk factors in my patients, I definitely make an attempt to ask about mood and mood-related issues. So if the patient has a history of depression or mental health disorder earlier in life, that is definitely a risk factor. The accumulation of chronic medical illnesses, so diabetes with neuropathy and high blood pressure and heart disease or stroke absolutely can layer on each other. Women more than men, and people who may be socially isolated. So those who are single or divorced or have lost adult children due to disease. Risk factors also include brain disease such as dementia, alcohol use disorder, certain medications like benzodiazepines and beta blockers, and of course, life stress. So our older patients do accumulate a lifetime of stressful events. They experience functional, personal, social loss, and this can be a risk factor for depression. Next slide. Up to 15% of widowed adults have potentially serious depression for a year or longer after the death of the spouse. And we do keep a close eye on patients who have lost a loved one, and we may screen on multiple occasions to ensure that they are socially supported and have not developed major depressive disorder due to the loss of a loved one. Now, there are medical illnesses associated with depression, and I hinted at this before. So folks who have experienced a CVA or stroke have up to a 60% chance of developing depression, certainly Parkinson's disease, coronary artery disease, and those who've had a myocardial infarction or a heart attack. And up to 40% of people who suffer from AD or Alzheimer's disease can also experience depression. And it is very important to aggressively manage depression in these patients because they can have worse outcomes from a medical perspective, and certainly for people who have cognitive issues such as Alzheimer's disease. We want to aggressively manage their depression because depression can worsen someone's functional ability and make someone's short-term memory or other memory issues look worse than they actually are. Now, elderly folks who have depression have higher rates of cognitive impairment, and we can actually see this on imaging, depending on the studies that you look at. So we do see cerebral atrophy, enlarged ventricles, and deep white matter changes associated with this. And as I mentioned before, it's often difficult to distinguish depression and early dementia. And oftentimes for a patient that is coming in for an initial workup with early signs of cognitive impairment, we may treat depression and then reevaluate someone's memory status or reevaluate the diagnosis of dementia to see if cognitive loss has been improved with the aggressive treatment of depression. And so this might warrant serial MOCAs or serial MMSEs. Next slide, thank you. The workup of someone who's coming in with low mood or depression would include checking for a complete blood count, looking for any kinds of subtle infection or anemia, which may lead to fatigue and low mood. We would check a complete metabolic panel to look for other signs of chronic disease, such as renal impairment, glucose impairment. A thyroid evaluation would be important. So both hyper and hypothyroidism can appear symptomatically as low mood or subtle memory impairments. The same for vitamin B12 deficiency. So we want to make sure that vitamin B12 and folic acid levels are checked, and if low, replaced. We would also evaluate fairly aggressively the patient's medication list and make sure there are no problem medications, and then take a detailed social history to see if there are any stressful factors that may be contributing. Thank you. Now, in regard to the treatment of depression, really patients benefit from a dual approach, looking at both psychotherapy and pharmacotherapy used in conjunction. We know patients who are accepting of that have better outcomes to treatment. And it's important to remember that treatment does improve quality of life, it does enhance function, and possibly increase longevity and their medical status. So we do want to really encourage our patients to aggressively be treated. Patients should be reminded that recovery can take anywhere from 6 to 12 months. So while we want them to feel better right away, it can take some time, but they should see some benefit in their symptoms within 4 to 6 weeks. And relapse can be high, up to 40%. So even though a patient may start to feel better in 4 to 6 weeks or 3 months, we do want them to maintain their therapy. Now, in regard to psychosocial techniques, we really want to address life stress, family conflicts, reduce social support that older adults might experience, and really work to improve their self-esteem, self-efficacy, and coping mechanisms. And while me as a primary care doctor, I'm not trained to do psychotherapy, I really do at each visit try to assess coping, assess their self-efficacy and esteem, and really try to do what I can to improve that. And of course, if appropriate, refer to a psychotherapist who can really perform CBT or cognitive behavioral therapy or supportive psychotherapy or problem-solving therapy, which have been shown in studies to improve the outlook for depression. We also like to encourage physical activity as tolerated, social activities with their church or community, groups that they might be a part of, and sunlight, so and a healthy diet. So really we're trying to approach stress management from multiple avenues. And it's important to remember that older adults have better treatment compliance, lower dropout rates, and a more positive response to psychotherapy than younger patients, despite the fact that older adults are often reluctant to engage with a therapist. And I do like to remind people that I think sometimes older adults can't envision what therapy might look like, and it's important to remind them that it is problem-based therapy. They aren't asked to revisit episodes that occurred in their youth or details of particularly tragic or painful events that happened many years ago. Therapy can focus on how they're feeling today and how to manage those feelings and develop coping strategies. So it should be a positive experience. In regard to depression and management, 4 weeks is adequate to identify patients who may need medication or dose adjustment. So now we're talking about the medication approach. And although we want our patients to feel better within a week or two, up to 4 weeks is needed to see some benefit. They may not feel completely back to their quote old self, but they should see some benefit. And it is important to follow up if you're the prescribing provider with a phone call or a visit within the first couple of weeks to make sure that they are actually taking the medication as prescribed, that they haven't developed some sort of a side effect, or that they just are unsure about the medication and haven't started it. So a little bit of encouragement is actually very helpful. I'm going to switch gears and talk just very briefly about anxiety before I turn it over to Dr. Grbić, who's going to talk about medications. And anxiety, again, very common in our older adult patients. There are multiple conditions that are classified as anxiety disorders. So panic, agoraphobia, social anxiety disorder, OCD, hoarding, and even PTSD. But the one we're going to focus on today is generalized anxiety disorder. And generalized anxiety disorder, the distinctive features or the distinctive symptoms that you would see would be patients who are coming in with excessive anxiety and worry. They're feeling fatigued very, very easily. They experience muscle tension, difficulty concentrating on a task. They may not be able to make a decision in a timely way. They might feel irritable or on edge. And for a sort of the classic diagnosis, these symptoms should be present for at least 6 months with a sense that one cannot control the anxiety and may have more than one stressor. Now, it's important in these patients when you get the sense that someone may be anxious or, and they may not come and tell you, I'm feeling anxious, I need to be treated for it. You might see this. You might sort of get the sense that someone's anxious about a condition because they're repeatedly checking their blood pressure, or they are calling you to discuss the same issue multiple times, but it's not an issue related to memory. They just are unsure of how to proceed with a particular decision that they need to make. And on interview, it's important to talk about the nature and course of their symptoms. So how long have they experienced this? Have they been a lifelong person with anxiety? Has that always been the case for them? Or is this something that is new in onset and have decisions become more difficult recently? We also want to determine the nature of the patient's mental status. So is there accompanying memory impairment, accompanying depression? Are they is it affecting their day-to-day life? So is their world actually becoming smaller because they are too anxious to engage in the world around them? We want to explore their social systems and their social context and support systems. And again, whether it's impaired, they have experienced some impaired function due to it. Again, we want to review their medications, as some medications can exacerbate the symptoms of anxiety. So one that we see commonly can be a patient who has hypothyroidism and maybe their levothyroxine dose is inappropriate and they appear hyperthyroid. We also want to assess for substance abuse. I have seen patients who self-treat anxiety with drugs and alcohol, and we want to help those patients get to a safer treatment approach. Again, lab tests would be important, the same lab tests that I mentioned earlier for patients with depression. And then if you would like to perform an evaluation, there is the GAD-7 tool. Next slide. Which asks the following 7 questions of your patient. So over the last 2 weeks, how often have you been bothered by the following problems? And have you been feeling anxious, nervous, or on edge? Can you not stop or control your worrying? Are you worrying too much about different things? Do you have trouble relaxing? Are you restless? Are you easily annoyed or irritable? And are you afraid as if something awful might happen? And you can score this, and a score of 15 or more would be suggestive of generalized anxiety disorder that would warrant treatment. And this is something that you could talk to your patient about and have them fill out with or without you in the room, and then go over the results together. Now, patients with depression can have marked anxiety. And so we do see that, we do see both disorders in conjunction with each other. And it's important to remember that the expression of anxiety may be more culturally acceptable in older adults than the expression of depression. And I always like to think about the context in which my older patients were brought up and in which they lived. So culturally, for some, depression is not something that is recognized. And these patients can present with anxiety or more of a somatic complaint. And so just something to think about there. And if a patient is complaining of anxiety or showing signs of anxiety,
No,
you do
this is fine. This is great, Tina.
for concurrent major depressive disorder. Now, there are medical illnesses that can mimic anxiety disorders and vice versa. So very recently, I've been managing a patient who has very advanced pulmonary disease. She has end-stage COPD, and to distinguish between respiratory distress and anxiety has been particularly complicated, and she's actually being treated for both concurrently because we can't tease apart which is actually causing her the distress. So COPD and other pulmonary conditions can mimic or exacerbate anxiety. People who experience nasal congestion, breathing difficulty for things as simple as a common cold or influenza can exacerbate anxiety disorders, particularly in someone who is more at risk or has a history of anxiety. Certainly cardiovascular conditions, hyperthyroidism, as I mentioned before, either due to inappropriate medication dosing or the actual condition, can have symptoms that mimic or exacerbate anxiety. And then angina or myocardial disease, so heart disease, may be exacerbated by high levels of anxiety, as patients can become very hypertensive. And again, so a thorough assessment, clinical history, physical exam to evaluate these before treatment begins. Next slide. Now, in terms of psychological management, again, we strongly recommend cognitive behavioral therapy or psychotherapy. For patients who have anxiety, and things that are very effective would be relaxation training. So music, visual imagery, aromatherapy, and instruction in relaxation techniques. And I often recommend patients explore some of these on their own while they're waiting for the referral or while they're waiting for appointments. There are different apps that they can download to a smartphone that will walk through guided imagery or meditation, yoga, and the like. And those are free or for a nominal cost. And then, of course, when they do establish with a therapist, they can undergo cognitive restructuring or exposure with response prevention and other psychotherapeutic treatment options. So I'm going to hold it right there for the medical piece, and I'm going to turn it over to Dr. Gurvich, who's going to talk about the pharmacologic management of depression and anxiety.
Thank you, Dr. Sagal. So we're going to just focus on the medications to treat both disorders. Next slide. So my approach to everything is a little bit different than that of a physician or another provider, because I just hyper-focus on the meds. So what I'm really looking for before we recommend treating anxiety or depression is looking at the medications the patients are already on to see if any of them can contribute to either anxiety or depression. Because what we really want to avoid is more medication cascades, which is what happens when a patient presents with a symptom that we think is a new medical problem as opposed to a drug side effect, and add on to the med list as opposed to backing off and seeing if the medication that's causing the side effect could actually be discontinued. So there are a number of medications that can cause anxiety. Some of them are over the counter, like decongestants like pseudoephedrine or phenylephrine. And those things patients won't always tell you about when you're talking to them. So it's really important to kind of dig a little bit and find out what they're taking over the counter. Beta agonists are now always being given via inhalation, but we've got to remember we're dealing with frail older patients who sometimes will develop anxiety, especially after a nebulizer treatment, or when they're using albuterol as opposed to Zolpidem. Zolpidem generally tends to be better tolerated and doesn't have the CNS component that albuterol can sometimes have. Bupropion, a commonly used antidepressant, is quite activating and sometimes presents in an older adult with agitation or anxiety. Fluoxetine, the most activating SSRI, can also contribute to that. Obviously, stimulants. Steroids actually go both ways. They can either cause anxiety or depression. And you always want to check how much caffeine the patient takes in on a daily basis. Beta blockers can cause depression and fatigue, so can clonidine because it's centrally acting. Benzodiazepines are depressants in and of themselves, which is why they can cause problems. There are interesting studies showing that finasteride, because of its mechanism of decreasing testosterone levels, can actually cause low mood in men. Progesterone can do it. Sedating antihistamines, most of which are over the counter, with the exception of hydroxyzine. So all of those can contribute to depression. Muscle relaxants, again, steroids, narcotics, and endomethacin. Endomethacin is an NSAID, but it's an old one, and there are old studies showing that when used chronically, it can cause depressive symptoms. And then some calcium channel blockers, particularly verapamil or diltiazem. Next slide. So I want to review briefly the Beers criteria and their look at anxiolytics and antidepressants, and both those classes are on the Beers list. Anxiolytics, because there's really an increase in sensitivity to how older adults respond to them. They're going to have more side effects. Patients who take them are going to be more at risk for cognitive impairment, delirium, falls, fractures, motor vehicle accidents. There is slow metabolism, with the exception of just one or two benzos that are not affected by age. So you're going to have a more pronounced response to a lower dose. So you really have to keep track of the dosing and only give it when necessary. With antidepressants, all of them are on the Beers list as well. So for the risk of increased risk of falling and dizziness. So when we start any antidepressant, we really want to make sure to keep track of that dose and titrate very slowly and monitor for dizziness and document all falls and figure out why they happened. Increased risk for cognitive impairment when you're using any tricyclic, even the better tolerated ones like nortriptyline and dizipramine, they're still anticholinergic, so they can cause cognitive decline. And paroxetine, which is an SSRI, obviously less anticholinergic than all the tricyclics, but still a +1 on a 4-point scale. So you have to keep in mind that when you're dealing with a cognitively impaired patient who is using paroxetine. They can all cause hyponatremia, especially at higher doses. We see that very often in older patients. So I'm always monitoring for that when I'm looking at medication lists. And then dosage adjustment. Obviously, if the creatinine clearance falls below 30, you do want to be careful with some of these. Duloxetine is a really good example of that. So keep an eye on that kidney function as it drops below 30. And then bupropion was actually removed from the Beers list because it was decided that it increases the risk for seizures, and it does that across all ages, not just the older adults. So for that reason, they removed it. But with bupropion, what I see a lot is sort of exacerbated side effects. So a lot of anxiety, often insomnia. Sometimes that anxiety turns into agitation, and sometimes you get weight loss with it, which is quite significant. So those are the things you're keeping in mind when you're deciding to use or not to use bupropion. Next slide. So obviously benzodiazepines are the most effective and the fastest onset medications that we can use for anxiety. And sometimes they may be appropriate in very acute situations where you really can't wait 4 to 6 weeks for another anxiolytic to kick in. But we do have to remember increased risk of falling and cognitive impairment. So you really only want to use them when symptoms are severe enough to warrant immediate intervention. And then what you want to do is start an SSRI or an SNRI at the same time. And really the goal should be to discontinue the benzo as soon as it's possible so that the patient remains on an SSRI or an SNRI for long-term treatment of anxiety. That's often hard to do, but we have to try. Next slide. So here's a quick chart looking at most of the medications, most of the benzos used for anxiety. I didn't include all benzos because not all of them are approved for anxiety. Some are approved for insomnia, and we're going to talk about them later. But the 4 that I have listed are commonly used for anxiety. If you have to use a benzo, my favorite one is lorazepam. The reason I like it is because its kinetics is not affected by age. So half-life is not going to extend in an older patient. It doesn't have a super quick onset of action, so it's not quite as addicting as something like alprazolam, for example, which is very difficult to get off of. So if you have to use anything, I would probably use lorazepam. I would start with a very low dose of 1/4 milligram and titrate up extremely slowly um, to obviously the lowest effective dose. Just a few things to point out here. Clonazepam is a longer acting benzo. The half-life is up to 40 hours. Onset of effect is fairly slow. It can accumulate pretty extensively, so I really don't like it in older adults, especially those with cognitive impairment and those at risk for falling. I've never seen a patient not get hooked or addicted to Xanax. Once you start it, it's very difficult to get off. Most patients want it once a day, then twice a day, then 3 times a day. And so you really have to be careful when you start that medication. I think the reason for that may be that Xanax is bound really tightly to the benzo receptor. And so it's really hard to get it off of there. And so clinically speaking, you can get really addicted to it. Buspar is a different medication. It's a SSRI of sorts. It's also a serotonergic agonist. So it very much works like a citalopram or an escitalopram or something like that for anxiety. And really for long-term generalized anxiety disorder, this is probably the better choice. The thing to remember is that you have to take it on a daily basis as opposed to PRN with all the benzos. And you have to titrate up the dose. So the starting dose, we usually start people very low at 5 milligrams at bedtime, sometimes 5 BID, but you do have to work with it and increase the dose. The usual range is about 20 to 30. The max is 60 milligrams. We don't have anybody on that high a dose, but that is possible to go up. So its effects are not immediate, and it takes about 4 to 6 weeks to see any effect. Next slide. So a little bit of a closer look on to Buspar. It is a serotonin agonist. It's approved for generalized anxiety disorder. It takes a while to see benefits. So when Buspar first came out, I think back in the 1980s, people didn't use it much. Everybody loved their benzos. Benzos work immediately. Buspar takes 4 weeks to kick in. Nobody wants to wait that long to feel less anxious. So it got pretty bad usage. And then over time, we realized this is how we're really supposed to treat anxiety. And so we've started using it a little bit more. It does not cause respiratory depression. It's a little less likely than a benzo to cause cognitive impairment or falls. Generally fewer drug-drug interactions, although you do have to keep in mind serotonin syndrome if they're on a trazodone and an SSRI and a Buspar or a tramadol, for example. So you have to kind of be careful with that. Is it helpful for agitation and anxiety in patients with dementia? It's case reported only. There are really not a lot of randomized controlled trials to support use, but we do find that occasionally it works well. And you have a couple of references there for you if you want to look into it some more. Next slide. So the long-term treatment of anxiety is really with your antidepressants. So first line would be citalopram, escitalopram, sertraline. Although sometimes in some patients, I actually see sometimes anxiety gets worse with sertraline, so it's very much case by case, but citalopram and escitalopram are really my first go-tos. You can also try an SNRI, venlafaxine, desvenlafaxine or duloxetine. With something like venlafaxine, it's obviously it's a dual receptor drug, so it does hit norepinephrine at higher doses more, and so at lower doses it may be an anxiolytic, and at higher doses it can exacerbate anxiety a little bit. So you have to keep an eye on the dose. Your alternatives are things like Remeron, Trintellix, and again Buspar. Remeron and Trintellix I don't think are approved for anxiety, but there's good evidence that it can be effective as well. Next slide. Next slide. So here's a list of things not to use for anxiety in older adults. You want to stay away from paroxetine because of its anticholinergic effects. You want to stay away from Prozac because of its long half-life and really activation associated, with exacerbated anxiety. Fluvoxamine is something we just generally don't use. Lots of potential for drug-drug interactions. Tricyclics you want to avoid because of cognitive impairment and increased risk for falling. MAOIs just because of its safety profile. Benzos you really want to limit use or avoid altogether for the reasons we already discussed. Beta blockers, generally, they can contribute to depressive symptoms, cause a lot of fatigue, exercise intolerance, and so not a good idea. And then antipsychotics and mood stabilizers, very little evidence for efficacy, and obviously black box warning for antipsychotics. So you really want to reserve those drugs for someone who is agitated to a point of when interfering with care or a danger to a caregiver. Next slide. So now we're going to get into antidepressants, and obviously there's lots of neurotransmitters involved: norepinephrine, serotonin, dopamine. So those three receptors are really involved into the treatment of depression. Next slide. So how effective are antidepressants in older patients? They're about as effective as they are in younger ones. 50 to 60% of the time, the antidepressant will work. There's been a number of clinical trials looking at older patients. It's kind of funny because they always look at 55 and over. That would include a lot of us in this group, I think. We're obviously not dealing with 55-year-olds. We're dealing with 75, 80-year-olds, 90-year-olds. But the point is that these antidepressants are really probably just as effective in an older adult as they are in younger patients. What you do have to pay attention to more is the side effect profile, because older adults are going to be more sensitive to the side effects of any drug, and withdrawal rates as well. There seems to be a higher DC rate with tricyclics versus serotonin reuptake inhibitors or SNRIs, which is why we use them more often. And really, when you're selecting an antidepressant, you really have to look at patient symptoms and the drug side effects and really try to match them up as best you can, keeping in mind drug-drug interaction potential, because these older adults are going to be on a lot of other medications that could potentially interact with antidepressants. Next slide. So this is quite a busy slide. I hope you can see it well, but what I wanted to point out a few things, and then you can look at these slides after and kind of relearn a lot of this stuff. So the biggest issue with older adults and antidepressants is dosing. So the dose range listed in this table, is the starting dose is really key, lower than in a younger patient. So if citalopram, you would start 10 milligrams to 20 in an older patient, in a younger patient. In an older patient, you really want to start with 5 or 10 and not go up above 20 because of QT prolongation risk. With escitalopram, you can start with as low as 2.5 milligrams to 5 and really go only up to 10. Fluoxetine, again, 5 milligrams to 30. I really don't like this drug because it's very activating, but in some patients it can be effective. Paroxetine, again, if you are going to use it, again, lower the dose. And sertraline, the starting dose would be 25, not 50, and the max should probably be around 100. Anything above that would be considered high. The other thing you want to look at is drug-drug interaction potential. And so I've listed the CYP drug metabolism issues with these drugs. What you really want to pay attention to are potent inhibitors. So like one of the reasons we don't like fluoxetine is because it's a potent 2D6 inhibitor and can really interact with other medications. Paroxetine is also a potent inhibitor, also higher risk for drug-drug interactions. A lot of these drugs are substrates for the CYP enzymes, so interactions are still possible with them where their levels will go up or down, but generally speaking, that can be avoided. Issues can be avoided with lowering the dose and titrating things more slowly. In terms of side effect profiles, sertraline is known for their GI stuff, so diarrhea, nausea, vomiting is a little bit more common with sertraline, so that's another reason to start with a lower dose and monitor the patient carefully. Next slide. Some of the serotonin and norepinephrine reuptake inhibitors, we've got Effexor, we've got Pristiq, we've got Cymbalta, and we've got a new medication that I can't even pronounce the name of, which we have not used in our clinic yet. It's fairly new. My favorite one is probably duloxetine because it's also effective for depression, anxiety, and pain. You can kind of hit a bunch of different problems with one drug. Venlafaxine or Effexor, you tend to see a little bit more an increase in blood pressure, especially at higher doses. You can have sweating. Patients experience that with this drug as well. So again, dosing is key. Start with a low dose. With venlafaxine, sometimes I even start with, if it's immediate release, I start with 37.5 milligrams and titrate up very gradually. So those kinds of things you want to keep in mind. Next slide. So overall, in terms of side effects, you're looking at GI stuff. You're looking at restlessness, nervousness, sexual dysfunction. Actually, sexual dysfunction is common with all antidepressants, much more common with SSRIs. Wellbutrin sometimes is used to diminish sexual dysfunction, and mirtazapine seems to be lower on that side effect profile as well. That could be a huge showstopper for a lot of the seniors because sometimes it's the one thing that's left that they enjoy in life, and when that goes, we run into trouble. Obviously, dizziness, fall risk, and fractures. For high blood pressure, SNRIs put you at higher risk for that. So again, lower the dose and titrate slowly. The other thing you want to keep in mind is that there's an increased risk for bleeding, especially when they're also on NSAIDs, aspirin, Plavix, or other anticoagulants. So that's something to keep in mind. Again, hyponatremia at higher doses, and serotonin syndrome when they're on a cocktail of an antidepressant and a little trazodone and a little tramadol, and there's your Buspar, and there's your serotonin syndrome. So when you stop one drug, you really want to taper it slowly. When you're changing from one drug to another, you want to cross taper, decrease the dose of the first and start a low dose of the second, and kind of cross taper over several weeks to months. Next slide. So some of your miscellaneous agents, mirtazapine, we use it a lot in our clinic. We use it for patients who are having trouble with sleep, having trouble with maintaining weight. It's got a lower risk of bleeding as opposed to SSRIs or SNRIs, really minimal drug interactions, and really quite effective. The lower the dose, the more sedating the drug is. So at 7.5 is really the ideal dose for insomnia and depression. And if depression is the predominant problem, then you go up on the dose. Bupropion is a very activating drug, but there is room for it. There are going to be some patients who have very low mood, can't get out of bed in the morning, have absolutely no energy, and they kind of need a kick start to their day. And that's when bupropion can be very helpful. It's also least likely to cause sexual dysfunction, and it actually can improve serotonin-induced sexual dysfunction. So that's a benefit of it as well. Trintellix is sort of a newer drug that we really don't use much. I don't know that there's a benefit to it over the others. It's kind of a weird drug. It's a serotonergic drug, but it hits serotonin from many different directions. Right now, it's brand only. It's quite expensive. It's not covered by a lot of insurances, so we tend to stay away from it. Next slide. So general recommendations for initiating antidepressants. Select agents based on patient symptoms of depression and drug side effects. That's really a good approach to start with, because you'll pick something that'll cause some side effects first, which will actually help their depression, if that makes sense. You always want to start low and go slow and increase very gradually, sometimes getting to a maximum dose, but not necessarily. You may find that in older patients, it takes a little bit longer to achieve maximal results. You want to avoid anything with anticholinergic properties. And you also want to avoid medications that can cause cognitive impairment. And you really want to try using single medications as opposed to polytherapy, just because these patients are already taking a bunch of drugs. You don't want to increase the risk of polypharmacy. You don't want to increase the risk of an adverse event. So using single agents is very much preferred in an older adult. I think that's my last slide.
Okay, thank you, Dr. Gurvich, and thank you, Dr. Sagal. I know we're running a little bit short on time, but I wanted to see if anybody had any questions. I know we have one in the chat. So we have a question. Dr. Hubi said, if we have to change an SSRI to another SSRI, do we have to taper the dose, or can we just change right away?
You know, I think it depends on the dose. So if you're dealing with Prozac, you don't. Prozac has such a long half-life, you can just discontinue it and it'll titrate itself off. If they're on a high dose of one SSRI and you want to start another SSRI, I would back off the first one and start a low dose of the second one and do it gradually. I don't know that there's necessarily good guidance for that, but I think it's always a safer approach because every SSRI is slightly different and the response to it in an older patient will be different.
Thank you. And then can we have, oh yes, I can send, I can send the slides after this, but Nicole asked, any best, let's see, any best options for patients with severe depressive features to see some benefits sooner rather than later?
I'm sorry, what was the question?
I think it was any best options for patients with severe depressive features to see some benefits sooner rather than later?
Do you want to take it, Dr. Sagal, or do you want me to do it?
Well, I think from a dual approach, like so from psychotherapy and medications, I think getting someone involved in psychotherapy early and aggressively, I think is really important because they can assist with coping strategies and therapy while the medications start and ramp up. And then, I mean, Dr. Gurvich, in terms of medications.
So I think that's a really interesting question because I think SSRIs and SNRIs really are effective for mild to moderate depression. For severe depression, so the tricyclics have always been the gold standard, but we don't want to use them in older patients. So I remember when Remeron first hit the market, which was many years ago now, it was actually compared in efficacy to a tricyclic. And so at least when it initially hit the market, it was considered to be a more effective drug for severe depression. So my guess, I would start with that if you're dealing with that.
But just be careful of the TCA side effects.
Right, no, but that's why we're using mirtazapine.
Oh, sorry, yes.
And that's Remeron at higher doses, right?
Yeah,
Sorry.
the higher doses are really effective for depression. The lower are more effective for sleep.
Okay,
Yeah.
thank you.
And you can, like, you know, in the chart, I think the maximum said 30, but you can actually go to 45 if you need to. So there's a little bit of wiggle room.
Okay.
Any other questions for Dr. Sagal or Dr. Gurvich? Okay, well, I think we, since we're so short on time, I think we're going to actually move the case presentation to our next session. But I did want to thank NP Vidal for submitting a case. So we're actually going to move it to the next session because I don't want to keep you guys over. I know everybody here is quite busy. But I did want to remind everybody that after this session to please fill out the CME HP form. I'll send the links out via email with the case, with the PowerPoint presentation so that you guys can keep that for your records. And then also, we really appreciate it if you can also fill out the session evaluation. That just helps us with our continuous quality improvement efforts. And you also have the opportunity to request any topics that you want to learn more about in regards to geriatrics. As a reminder, our next session is on February 5th. We'll focus on insomnia and psychosis, and we will have another case discussion, and we'll make sure to leave time for that for the next session. And again, I wanted to thank Dr. Sagal and Dr. Gurvich for presenting today's a didactic presentation. Looks like we do have some other questions if anybody wants to stay behind and answer these, but Beatrice Videz said, any thoughts on the use of cannabis or CBD products for depression or anxiety treatment? If you want to answer that now, since we have a little bit of time.
So if you look at the clinical trials and cannabis, there's very little data in your older adults. Most of the, I've actually researched this quite extensively. Most of the studies have very low ends. So like the number of participants are often less than 20. And most of the patients in those trials are younger patients. So we have very little information on how patients will respond to any kind of cannabis. My biggest concern is cognitive impairment, falling. If they're smoking it, they have pre-existing respiratory disease. We just, lots and lots of drug interactions. We just had a case at the Senior Health Center last week with someone who was potentially at really high risk for a drug interaction because he was taking cannabis, and he didn't tell anybody about it until my resident spoke to him and kind of dug a little bit deeper. I would not recommend cannabis at this point for anxiety or depression in older patients. THC is known for its sort of psychotic kind of a picture as well, and you don't want to exacerbate any of that. And it's very difficult to get actually pure CBD oil at this point. So I would not recommend it, not yet. We need to have more studies.
Thank you, Dr. Gurvich. Any other last minute questions? Okay, thank you everyone for joining us today, and we hope to see you at our next session on February 5th.
Thank you.